This is a new competition. It sits underneath the Data to Early Diagnosis and Precision Medicine Industrial Strategy Challenge Fund challenge. 17 million from UK Research and Innovation and up to 3 million from Cancer Research UK. So you can have these slides and they'll all be available, so don't worry about taking pictures, unless you want to tweet things, that's fine. So I think it's worth going back to the industrial strategy. You know, before you apply for this competition, I would say treat this a little bit as your bedtime reading. This is what it's all about from UK Research and Innovation's perspective. And the Industrial Strategy Challenge Fund is a £2 billion fund to increase UK productivity. So it's very exciting. Have a look at this, also the Life Sciences Industrial Strategy, and look at what we're building on. This Data to Early Diagnosis and Precision Medicine Challenge sits underneath the AI and data economy sort of section of the industrial strategy, but it's clearly very closely aligned with the ageing society as well. So this is the Data to Early Diagnosis and Precision Medicine Challenge, a £210 million investment. It has 3 strands: genomics, digital innovation hubs, and then digital pathology, radiology, imaging, AI, machine learning, and integrated diagnostics, which is 72 million in total there. I think it's important to say that because it sits under that 3rd strand, it doesn't mean that you have to work with an existing centre of excellence in digital pathology and radiology. We would love some of those centres to be involved. We would like some of those centres to either be in consortia or to lead consortia, but it is not a requirement. You know, it's where it makes sense. If it makes sense for you to do that, fine. If it makes sense for you to pull imaging data from elsewhere, that's fine too. But we just welcome, obviously, building on investments that have been made to date. These are the 5 centres of excellence. Many of you will be familiar with them. If you're thinking of doing something that will include digital pathology or radiology, I would certainly say it's worthwhile having a conversation with them. But many of you may have already built up fantastic relationships and have got some really good ideas of what you'd like to pull. So this is a definition that we've put in the briefing document of integrated diagnostics. I won't read it, it's there for you. If there's anything that you think is missing that you'd like to see there, please chat to us, because it may well be in scope, but obviously we didn't want to write a book. And in fact, we wouldn't have been allowed to go over our word count, which I'm already in trouble for. So yeah, the challenging the multidisciplinary consortia to work with the UK infrastructure to develop integrated diagnostic solutions is fundamentally what this competition is all about. So I wanted to mention the Wave 3 ISCF challenge, which is accelerating the detection of disease. And this has been announced with a £79 million investment. The reason I've put it up there is actually to say that this is not the same thing. This is a completely different challenge. It is aligned with the Wave 2 Data to Early Diagnosis and Precision Medicine. It's aligned with the aims of the Life Sciences Industrial Strategy, but this competition fits underneath Wave 2. And I am aware that it has caused a bit of confusion, and I understand that, because enabling integrated diagnostics for early detection kind of sounds a little bit the same, but it is underneath Strand 2. So what you want to be looking at is the Strand 2 investment. This is a slide that Karen put together. Thank you, Karen. I think that we all know that healthcare is changing. We're entering a new era. We can't keep going either within the UK or certainly within the US with the amount of money that we're spending. We have to think differently. And so we're starting again to look at care in the community, looking again at what happens within a healthcare continuum, bringing together different omics, bringing together data and omics, and hoping, well, not hoping, but actually recognising upfront that we can get early detection and accurate diagnosis and have a real shift towards getting things in the community and having a major impact on the healthcare. So who can apply for this competition? So I think this is great because all the organisations that I think are in this room will be able to take part in this competition. Many of them, and the ones in red, are the ones that are the leaders. So UK registered business of any size can lead. So those of you who are used to the biomedical catalyst, where it has to be an SME, we're letting a business of any size lead here. It's all about delivering and working in partnership. UK registered research and technology organisations can lead, UK registered academic institutions, UK registered hospitals, and then some of the infrastructure that I've been mentioning can also actually lead an application. And Lydia from our competitions team will go into this in a lot more detail in terms of who can lead and what that might look like. The organisations that are in black can be within consortia, but not actually lead the actual application. So charities and other public sector organisations, for example, and infrastructure supported by UKRI. So I hope there's nobody in the room who feels that they have been cut out of that. We're very, very keen to really push this collaboration and partnership. You must have at least 3 partners, including the lead. And this is different from our standard collaborative R&D, where we say, well, a collaboration is 2 partners, that's okay. We're saying here it must be 3, and you must involve an SME, and you must involve either an NHS organisation or an academic partner. So that will make up the minimum of your consortium. You can bring on board others as well, and that's absolutely fine. So maximum grant of 3.5 million and a maximum project cost of 10 million. And this means that in line with the aims of the industrial strategy, we are looking to leverage money from industry. It doesn't mean that if you apply for a £3.5 million grant, you have to find the rest of the money from industry. That would be great if industry came in and you had 20 million in your partnership. We would obviously welcome that. If you do go above the maximum project cost, so not the maximum grant, but the maximum project cost of 10 million, please get in touch with us. I think it's very unlikely we'd say no. If you want to go above the maximum grant, that is obviously harder because we realise we're taking money there from other people who may be wanting to bid into the competition. But if it's a small amount, we will certainly discuss with you because the last thing we want you to do is to aim for something where you're not going to be successful because you're essentially underfunded. So think about, how do I cut my cloth for a 3.5 million maximum grant? You can go for less, provided you fulfill the brief. And please, always, our door is open. Chat to us about your ideas. Maximum duration, 3 years. We've opened the competition. It closes on the 23rd of September at noon. Many of you will be used to applying for funding from other organisations that are perhaps a little less strict than our dear Lydia. But seriously, this is a very hard deadline, and please get everything uploaded and onto the site the day before. Make sure everything's as you want it to be, because it is a hard deadline. And even if you were to call me at 1 or 2 o'clock and say, I couldn't do this because there isn't going to be a lot I can do about it. And I've felt the pain of people sometimes. So it's always worth really stressing that. Lydia will go a little bit more into this, 50% of eligible project costs being taken up by research organisations. So this is what we want your project basically to do, what we want it to look like. So you can focus on the early development of new combinations. So we might, for example, say, well, what about a combination of imaging, of digital pathology, with genomics, with specific algorithms? You know, that would be in scope. But also we will support later stage refinement, perhaps even utilising CE-marked products and bringing them together in a unique new way to offer improved diagnostic sensitivity, specificity, improved information that will support early diagnosis and precision medicine. So in the actual briefing document, there is more information on the scope, but in terms of the really big ticket things, you know, we will support integrated technological approaches, so the combination of different technologies, we really welcome that. We'll support new solutions in different care pathways, so that kind of integration as well. And then we will let you, as I was mentioning earlier, look at things like the health economic case, the clinical impact, we want this to be successful. Another thing we're very keen to see is patient engagement, clinical engagement. You know, it's unusual for a straightforward Innovate UK competition to be so patient orientated. You know, it's not that we don't want to support the patient, but we very rarely support actually that public patient engagement. You can have a work package in that for this if you think it's going to ultimately deliver your integrated diagnostics and aid in the uptake of your novel ideas. So, you know, we will fund the development of wearables and new diagnostic tests for use in the community, but we do want to stress this must be designed and developed alongside with professional healthcare specialists. It's not because we don't trust the Fitbits of this world or anything, but they aren't evaluated in the same way as a medical device. So, you know, work with people in that space. We will fund things and work packages that move into monitoring, that move into treatment selection and patient management. But don't forget, this is all about data to early diagnosis being the main challenge here. We want to see some component of early diagnosis, and we want to see a focus on that within your proposal. We're looking to fund a whole portfolio of projects. We don't know what's going to come in. I think that's very exciting. But we will be looking across different disease areas, technological maturities, so you know, some earlier phase things with some picking up on what's already out there and utilising it effectively and efficiently. And across you know, different disease areas too. So these are the diseases that are in scope, and it's not limited to these. But cancer, cardiovascular diseases, including stroke, inflammatory disorders, including the autoimmune diseases, metabolic diseases like diabetes, all these will be in scope. Neurodegenerative diseases, and that includes Alzheimer's and vascular dementia, etc. And then pediatric and maternal and fetal health. And this comorbidities one, I would really stress, is important to us for this competition. It's something that everybody talks about, everybody knows there's an unmet need. We don't handle comorbidity well. We all know that what somebody is badged as is often just the first consultant they had to see, that they went to see, rather than actually, you know, how do we really treat people with these comorbidities? What is it that we want to bring to the table? It's always worthwhile saying what we won't fund, because I think this is also in the briefing document. So we do welcome the social science component, but we don't want to focus predominantly on behavioural monitoring. So we have put, I mentioned the wearables, you know, they have to be prescribed by healthcare professionals, and you have to develop them with a healthcare professional, otherwise they are out of scope. Infectious diseases are out of scope. But infectious diseases may be in scope within a comorbidity environment or in scope within a precision medicine arena. So do talk to us if you want to look at infection. But think this is not to focus on antimicrobial resistance. One thing that would definitely be out of scope, for example, is multipathogen detection for sepsis. That would be clearly out of scope for this competition. So basic research is out of scope, so biomarker discovery, new detection technologies for which there's no proof of concept. That's out of scope, that's fantastic stuff, but much more blue sky research and supported more by the research councils than the Industrial Strategy Challenge Fund. We would like to build on existing capabilities within the infrastructure, but this is not about building new infrastructure, and neither is it about developing new therapies. So the funding, Lydia will go into this in a lot more detail, but I think it is worth saying that all academic partners of all oncology-focused projects will be jointly funded between UK Research and Innovation and Cancer Research UK. The percentage that will be supported by Cancer Research UK will be identified after we know who's won. So we don't know how many oncology projects are going to come in. We don't know yet how many academic partners are going to be within successful consortium. In line with the I must say the proportion of funding provided by CRUK will be the same across all academic partners. And this is just to keep it fair, and it's to keep it very simple. CRUK will receive a share of net revenue from the academic institutions and the intellectual property revenue that comes from that. That share will not be greater than 30%. It will be pro rata. So if CRUK, for example, is putting in 10% of the grant towards that academic institution, it will just be pro rata on that 30% will only relate to the 10%, in other words. And I think it's really important to say here that CRUK will not be entitled to any revenue arising from IP generated by the industry partners. So this is just the share that goes to the academic partner within a consortium. You'll see within the briefing document that you have Nicole's contact details. Nicole will be there to answer any questions from if you're concerned about this aspect. I think it's great that we're working with CRUK. It's great that we have an additional 3 million for you. And I don't think this is onerous. It's the kind of thing that an academic institution would expect anyway. Key competition dates, you'll see these again, I'm sure, but it is worth noting the competition closes on the 23rd of September. We will probably just use 2 of these 3 interview dates, but we would ask you if you put in an application to make sure that you're holding these dates. Don't think, oh, well, I'll just say I'd like to come on the 19th, because if everybody says they want to come on the 19th of November, then we will have a problem. So this has been our journey, really, to date. We really welcome your applications. We have a little bit of time now which we leave for questions regarding the scope, as opposed to questions regarding the process, which we will deal with later. So does anybody want to ask anything about the scope of the competition? It's all crystal clear. Yes?
I was still a bit confused. This is a problem. I was still a bit confused about the wave 2 and wave 3.
This competition sits underneath wave 2. So it's part of the data to early diagnosis and precision medicine. It is the 3rd strand of that wave 2 investment. Wave 3 has not actually started yet. Many of you will have been involved in getting the business case together, but it is a completely different challenge. Yes?
I speak for UCL. Can I ask about industry partners? I think I read that industry could perhaps need to be registered in the UK, but does it also include international industries that have a presence in the UK or have ambitions to come to the UK with new technologies?
It includes, you don't have to be headquartered in the UK. So, we have supported in the past many of the big players. So, Roche Diagnostics, for example, we've supported. So, the simple answer is you just have to have a presence in the UK and registered in the UK. If there is no presence in the UK yet, then I would say chat to us. Clearly, we welcome the inward investment. We welcome new companies coming into the UK that have not got a presence here at the moment, but we would expect them to register as a UK subsidiary, for example. But we would welcome that.
You talk about infrastructure a lot, but I'm not sure I'm clear on the definition of that.
That's really an interesting question. I haven't tried to define it per se. There may be somebody in the room who has a fantastic definition, in which case, please stand up and support this. But the infrastructure is either a consortium, in the case of a Centre of Excellence, that is just a consortium, but it is a consortium that has agreed to work together to support the community. So infrastructure underpins, basically, it underpins research, it underpins evaluation, and infrastructure is not virtual either. I mean, you do get some virtual things. Infrastructure has a real presence, so that the centres that we support, the work that is supported by the National Institute for Cancer, by NIHR, they are real entities, whether they're the BRUs, the BRCs, anything of that nature is classed as infrastructure. That is, so it's not, I guess one of the ways of looking at it is when funders support infrastructure, they're not supporting necessarily projects per se. Now, most of the competitions that we have run, certainly within Innovate UK, would not support infrastructure for infrastructure's sake. You're going to have to say, well, then I did this evaluation or I had a demonstrator. I don't like the word demonstrator because people get in their heads, they've tried it, they've demonstrated it works, then they're going to walk away. We want to fund things that are sustainable, that are embedded into the UK. So the infrastructure is what people come to and they work with and they build on and they learn from and they work in an integrated way. It's funded quite differently from resource, for example. If anyone from infrastructure would like to add to that, you're very welcome.
You mentioned on the slide that it was a minimum of 3 partners.
Yes.
I remember some of the slide. I remember when there's an SME.
Yes.
Well, it wasn't one. There was another one. Is there a limit to the number of partners? Not really, but and is there any limit on type partners?
So, okay, the other one was the NHS or academic partner. Is there a limit? No, there isn't a limit. However, when you put your bid in and it goes to the assessors, one of the things they're going to be asking themselves is the project management. If you have a really significant number of partners, what are they all doing in there? Are they all really being supportive? Do you need them all to fulfill your project, to deliver your project? But there is no limit. In terms of who can be a partner, you'll notice the slide that I put up that had the red that could lead and then the black that could be part of a consortium. That gives you who can be part of it.
So for that, you need to have an SMA and an NHS?
Yes. Yes.
Could you explain a little bit more about what you had in mind for the comorbidities?
Yes. Comorbidities are not handled well at all. So there's several sides of comorbidities. One is differential diagnosis, but I think people are used to that. But actually, wouldn't it be great if a patient was considered in his or her entirety with the comorbidities that he or she presented with that are real patients? So most of the trials that we have today are cancer trials, trials in cardiovascular diseases, trials in whatever. They're not real patients. So actually, how do you handle patients who come with multiple diseases? How do we handle the precision medicine side of that with the polypharmacy that we all see, which, there's lots of publications about the fact that that's not great for patients. But if you have an idea in that space, I'd be very happy, we'd be very happy to chat to you. A classic example we've funded in the past is, and I said infection was out of scope except with comorbidities. But, we have funded, we funded a project where infection was being looked at home. So essentially, this was Philips, and it's out in the public domain, so I can talk about it. We funded Philips to look at a little Coulter counter for use at home to look at neutropenia, so that if actually patients were neutropenic, they wouldn't have to go to hospital for their cancer chemotherapy. So there's a link there between infection and between cancer. There are many links between some of the metabolic diseases and cancer and cardiovascular diseases. So it's that kind of thing we're thinking of, but really getting it right rather than having it all siloed.
So currently a Eureka competition for collaboration with organisations in Singapore. Would that fit in with the opportunities in this competition, or would a Singapore partner be ineligible for this?
A Singapore partner would basically be ineligible because no grant for this particular competition can go out of the UK. There are certain cases where you can subcontract, but it wouldn't be a big part of your programme or a big partnership. And if you want to discuss that, we can discuss the details of what that subcontraction might look like.
You could have an overseas partner that didn't accept the basis of that partnership, if it didn't involve any monies going to that partner. They were just taking part in the activity and the ability, and they would get some benefits.
You can have a partner who receives no grant, who puts in money, who is overseas. But again, that's the kind of thing Lydia will go into in a lot more detail.
Thank you very much, Penny, and thanks to Karen and the rest of Innovate and everyone that's got us here to this point in this really exciting opportunity to work on this call together. I'll try and keep this relatively brief. I think Penny has very eloquently articulated why we're doing this, and I think what the competition is supposed to be about and wants to try and achieve. I thought what I could perhaps usefully do is to give you a little colour as to where our heads are at as a charity, where we see the shortcomings in our area, where the challenges have been in progressing research in early detection and diagnosis of cancer. Now, I very much get that the significant majority of the people in this room aren't necessarily cancer people, but I think a lot of the messages and the challenges that we face in the cancer community are generalisable and perhaps are pertinent more broadly. So I'll try and communicate it with that in mind. Very briefly, you probably all know what Cancer Research UK are. Big fundraising charity. We spend something like £450 million a year on academic and NHS cancer research. One of our big top-line strategic imperatives is we're trying to improve the survival rates of cancer. So around 50% of cancer patients survive cancer for 10 years at the moment. That is not great. And we see early detection as one of the main ways in which we're going to improve those survival rates. Our ambition as a charity is to get that survival rate up to 3 in 4, up to 75% within 20 years. And I think early detection is going to be key to that. You can see from the graph at the bottom that survival of colorectal cancer based on the stage at which it's diagnosed. So you get diagnosed at stage 1 when it's very small, it's localised. Then you're looking at a survival rate of something like 95%. You get diagnosed at stage 4 when it's metastasised, when it's spread throughout the body, and the survival rate is something like 5%. And that's the stark difference that early diagnosis, early detection can make, even with the existing therapeutic tools that we have at our disposal. So that's why we're in this. We define early detection essentially as the kind of discovery and translational research trying to establish very early detection of cancer at any point on the continuum, really, between, exactly as Penny put up in that deck slide at the start, where it said, you start off in inverted commas healthy on the left, and then you've got this probably simmering latent period where it's asymptomatic, where you're perhaps in a sort of pre-disease space, and in cancer that would manifest as early molecular changes that aren't really cancer, but that are cells that have started to go a bit wonky. Then you progress to asymptomatic disease, where you probably do have an established early cancer or whatever else your disease of choice is, but it's not yet manifest clinically. and then progressing into clinical. We're interested in accelerating detection at any point along that continuum, as long as it's making an impact on health and giving you an opportunity to intervene earlier, but crucially to intervene more appropriately. So a huge part of our vision for early detection and diagnosis is not just, can you build a magic doodad that goes ping when you've got disease at the earliest possible point, but that your doodad also gives us sufficient nuance of information that says what kind of disease you have and on what trajectory are you. Is this something that's consequential or inconsequential? Okay, so what we have to avoid by any detection or diagnostic strategy is something that just raises alarms and potentially overdiagnoses. So even if you're detecting something real, some kind of molecular aberration, we need you to tell us that that aberration is consequential. Okay, that it is going to end up hurting or killing the patient, and isn't just something that'll simmer away in the background for 30 years, not really make that much difference, and then the patient will die of something else entirely. Okay, so we need to think about over-diagnosis. So, given that early detection is so important, and given that we as an organisation have prioritised it, and we're not alone in doing so, of course, most of the disease-centric charities across neurodegeneration, cardiovascular disease, metabolic disease, rheumatic disease, they've all, to a greater or lesser extent, put emphasis on early detection. Why is this so hard? Why isn't this happening? So I'll tell you a little bit about what the challenges are in the cancer space, but again, I think a lot of these probably are quite genericizable. For starters, it's incredibly biologically complicated. So early disease doesn't necessarily look like late-stage disease, and I think a lot of the problems we've faced, particularly in the cancer field, are that the whole edifice of cancer research internationally has grown up around studying established late-stage disease, because that's where the patients are, right? So because early cancers are asymptomatic, then they don't get picked up, they're diagnosed at a late stage, so all we've got to look at biologically is what does a stage 3-4 cancer look like, and I'm sure that's the same for neurodegeneration. All you get to look at is the patient with clinically manifest Alzheimer's disease, and probably where they started off on their molecular pathologic journey. It doesn't look the same. So if you develop biomarker and detection strategies based on what late stage disease looks like, you may be looking for the wrong thing entirely. And the markers that would have found it early aren't necessarily there when you look at it late. So that's tough, right? It's biologically complex. You can't get necessarily model systems that fully recapitulate what early disease looks like. So there have been challenges there. There have been challenges, of course, in the technology. If you're talking about detecting very early stage disease, for cancer when it's just a tiny cluster of cells, then that's not much signal amidst the huge noise and complexity of you as an organism. So there's a technological challenge there in making something which is sufficiently sensitive to pick up early disease, but sufficiently specific to not just fire off false alarms all the time. Now, because of this sort of historical focus on late-stage disease, and that, of course, is true also for the pharmaceutical industry, where massive money is spent on treating late-stage patients, because, of course, those are the patients that are in the hospitals and that are dying. There's been a comparative lack of emphasis across the piece on putting money into early detection because of the perceived intractability, because of the complexity, because of the uncertain patient base. So this is something that we've tried to change by any number of means, but by putting money into it, but also by very actively engaging with the community and communicating and trying to get more minds turned to the problem of early detection, to get more academic institutions prioritising it, to get more companies engaged in it, to hasten knowledge exchange, to try and prevent redundancy of effort, but crucially to overcome a kind of fragmentation of effort in this field. If you look across the landscape of early detection research in cancer in the UK, you've got lots of little pockets of really great stuff dotted around the place. And you've got some fantastic, early cancer cell biology and molecular biology happening over there. And you've got some fantastic IVD, liquid biopsy stuff happening over there, and some fantastic imaging happening over there. Some really great population science and risk stratification going on over there. And it's, by and large, fragmented and siloed. And if we're going to get early detection of any disease right, we need integration. We need all of those parts to start sort of coming together, because any one technology or approach to early detection and diagnosis, any one bit of kit, any one marker signature from one modality of measurement is not going to give you the whole picture. In my personal opinion, I disavow any links to my employers. I don't think they'd say this publicly, but in my personal opinion, I think what's going to be needed to really get early detection and diagnosis right is an integrated approach. Okay, it's not going to be just I've got my CT scanner and then that's going to fix everything. You're going to need an integration of imaging with liquid biopsy, with molecular biology, with genetic predisposition, with whatever other population risk stratifier, to give you the complete picture of in whom do I need to look for this disease in the first place, who's at risk, because you can't scan everyone. Then how do I triage to find those at highest risk? Then which tests, be they molecular, imaging or other, do I need to perform on them to know that there is early stage disease there and what course that is likely to take. And I feel like each individual bit of tech has got hold of one bit of the elephant, right? So your CT scanner might tell you what the trunk looks like, but it knows bugger all about the tail. And your circulating tumor DNA assay might tell you another bit about the tail, but doesn't know that much about the legs, and so on and so on. So our hope is that through the integration of multiple technologies and approaches, we'll perhaps start to really get this right, to know who we should be looking in, to look in the right people in the right ways and get the right depth of information to really crack this problem. So hence us buddying up with Innovate for this particular call, because I think that's the ethos here. I probably don't need to bang on too much about how fantastic CRUK are and all these wonderful things that we're doing to accelerate the field, but we are. So if anyone's interested, come and grab me, and I'll tell you more about strategically what we're trying to achieve here. But a lot of this resonates with this particular call. Okay, it's about getting better at validating the discoveries that we've made and pulling those through and accelerating translation with the patient in mind, with the health benefits in mind, not only to the individual but to the population and health economically. As Penny was saying, none of this is going to count for anything unless the system is able to adopt the innovations that we're generating. So thinking through the intended circumstances of use of your test or your package of tests is crucially important. What is the requisite information that decision makers are going to need to adopt? And if you're not generating that, then you might as well not bother. And then, of course, health economically, is it feasible? Can the system bear the cost? Where does it sit in the pathways? All very important questions. I think encouraging this integrated, multidisciplinary, systems-based approach is really important. The human is a system, and so looking at any piece of that in isolation is probably not enormously helpful. And we have to think about that sort of integrated view of the biology that will give us the best picture. And of course, engaging industry is a cornerstone of our strategy, and again, made Innovate the sort of the perfect partners to work on for this call. We see incredible innovation going on, particularly in the SME sector, but of course also in the bigger companies. And stitching that together with the depth of biological insights and indeed the technological innovation coming out of academia, I think if we can eliminate redundancy of effort and encourage knowledge exchange and get people just talking to each other and showing each other their toys a bit earlier in the process, we're going to really accelerate the pace of progress here. So that's what we're keen on doing. So I think with that, I'll probably skip the rest. Thanks for your time. Do come and grab me if you want to chat. Happy to. Okay.
There's time for particular questions for David or points they'd like to raise.
So one of this is again on scope, but if you've got a Cancer Research UK funded researcher, do they count as your academic partner for the purposes of the call? So I'm thinking about someone like at a CRUK funded institute or
Yeah, sure.
Yeah.
So any academic researcher or research organisation is eligible to be the academic partner in the consortium. So yeah, could be at a university or could be at a CRUK institute or a welcomed centre or anything else. Karen, then in the middle.
If I can just say, we do, Lydia will come into it, we do define academic partners as the universities if they are the more infrastructure-orientated organisations like Welcome or whatever, they're classed as charities. And there's, Lydia will go into the different intervention rates there.
Right.
So we are looking for an academic partner and or NHS organisation.
Just from the point of view of early detection, obviously earlier detection of any form is a good thing, but for the purposes of this bid, do you have a specific definition in terms of stage as to what you guys would be calling early detection? Because obviously in diseases that are more commonly found at late metastases, even early metastasis is earlier, but that would still be then stage 4. So I just wondered, just so that we're not working on things that might end up out of scope.
Yeah. So I think the crucial thing here is earlier. I think you're going to need to establish that whatever your integrated diagnostic solution is, it's going to mean that people are picked up earlier in the trajectory of their disease and therefore have better outcomes. Now, there's no hard and fast rule about which stage of cancer or which, I don't know what the equivalent categories are for heart failure or anything else, but you're going to need to demonstrate like this is going to pick them up sooner. Yeah, it doesn't have to be only for asymptomatic disease or anything like that.
Earlier detection of relapse would be in scope, but it doesn't have to be that really initial early diagnosis, even though obviously that's objectives that people don't actually have treatments.
So, this is a comment for Penny really. I think the emphasis on early detection is absolutely critical, but it also applies to many other diseases as well, particularly, of course, autoimmune diseases. Now, you talked about, charities. I mean, would it not be sensible for people like Diabetes UK versus arthritis and, the other charities to be getting involved in this, to put some emphasis behind early detection of autoimmune diseases as well?
We have, actually, Karen attended on our behalf, meeting with the Association of Medical Research Charities, and there are a number of charities who are interested in taking part in this. It's unfortunately it's confidential.
No, that's fine. It's good.
But I think as a point of principle, absolutely. If a given consortium was of interest to, pick your charity of choice, and you wanted to get them on board as partners, I'd see no reason why that would be a problem at all. It'd be a very good thing, I think. And equally, we're happy to, co-buddy up if a consortium straddled different charities' interests. So there's a high rate of pancreatic cancer in new onset diabetes, and if Diabetes UK wanted to buddy up with us and do something in that space, great.
We do have an issue with pancreatic research UK as well.
Oh, well, that's
fun again. This is probably more observation than it is question, but I think I'll get a question at the end. When you put up, so I find interesting, the challenges, which is common to a lot of things, a lot of those with nothing to do with anything in medical or research. It was institutional, it was people, it was organisational, and it was all that kind of stuff. Always presuming we have to, but the knowledge is out there. It's just not joined up enough and it's not focused enough around some of these things. So when it comes to this next wave, how much credence is paid to, this is what I was going to ask about number of partners, and not necessarily granted partners that receive grants, but how much credence is paid to the actual model that we put forward for a bit like this?
I would say a lot. Have a look at the questions that you're going to have to answer, and it is about working in partnership, having the NHS, having hospitals, having academia, having the industry coming together, working on something that actually is going to be fit for purpose, answering that so what question, answering the, where do I put my solution, for want of a better word, which could be a product, a service, a process, where do I fit it into the care pathway? Am I going to model how I'm going to fit it best into the care pathway? How am I going to change that? So, am I going to be disruptive? Is there going to be a step change? So when I said we're going to take a portfolio approach, it may well be that some things are more incremental in their change. We welcome that because an incremental change can have a huge impact. But actually, are there real step changes there? And if you're at the earlier technology readiness level, looking to combine things possibly for the first time, I would expect there to be quite a lot of modelling, in terms of where the care pathway is and that, and how you're actually going to get the uptake.
Partnerships, we won't draw partnerships, you can do an Venn diagram or a diagram, and they look great. It's the formality and the structure and the relationships and transactions.
And that's a really big
and the legacy that it leaves.
Yes. Mm-hmm. Yes, and there are questions all around that. There are questions around how your team will benefit, how people beyond that will benefit, the experience that your consortium has in working in these multidisciplinary environments with multiple partners across the way. Or don't and will do at the end of it, but obviously, wanting to feel that you can deliver. And if you don't, then are the people in your consortium who can guide you to do that? Because one of the things the assessors will be looking at is there a gap in the capability of this particular consortium? Have they filled that gap? Have they got the right partners on board?
And that's the really key point. Yeah. So you're not going to get away with lip service in this, okay? No. So what you can't do is just assemble, 5 really pretty names and logos and stick them in a consortium, and that's we'll go, wow, that's so amazing.
We will notice.
Yeah. So I think to use a kind of crude footballing analogy, that this is about the team, and it's about how the different bits of that team interdigitate, and it'll be no good plonking a proposal down with 5 centre forwards on it and nothing else, right? Yeah. So you need the strikers, the midfielders, and then defence. You need and to say how these pieces are going to work together as a whole, without which you have nothing.
That's my question of partnership. So partners could be funded separately.
You can subcontract to a partner if you need to bring somebody on board.
It's separate.
Yeah, well, Lydia will go into how the funding works and the partnerships work. I think we've just got time maybe for one more question quickly. Yeah.
Actually, just following on from that. So if we look at sort of the current dynamic, we have the NHS, which is managing the group, often trying to sync what we're trying to shift as it doing into the community. So these new players, let's say smart city players,
yes,
could also be considered within that.
We'd welcome them. Yeah, it's looking across a healthcare continuum and looking to future-proofing.
Good morning, everybody. Okay, so my name is Lydia. I'm a portfolio manager for Innovate, and with my colleague Andrea, we're going to run through the application and assessment process from the Innovate point of view. So the information we're going to give you is really, really important. Every competition we run, people are ineligible because they didn't follow the guidelines. So the guidelines are here for your benefit, and we'd really like you to get through this competition. The competition has been through a lot of changes in its development. If you'd like a copy of this slide deck, it will be available, so you can contact our customer support team. A recording of this briefing will also be available through the KTN. As I said, there have been a lot of changes. If you have very specific questions, it's probably better emailing or calling in after this briefing. Some parts will be in detail, some parts will be a bit of an overview, but again, all the information is there in the guidelines on the website, and hopefully this will help you. Okay, so you've already heard about the scope, and there'll probably be a little bit of repetition in this from that, but we are going to run through the eligibility criteria, the Innovation Funding Service, or IFS, which is the system you apply with, application finances, academic partners, how to submit your application, how the assessment works, project setup if you are successful, and then we'll have questions and answers at the end. Okay. So, eligibility criteria. All projects must be collaborative with at least 3 partners, including the lead. You have to involve an SME and an NHS organisation or academic organisation. Any of these can lead, but you must be UK registered. You can be a UK registered business of any size, an RTO, an academic institution, a hospital, or an NHS or National Institute of Health Research organisation. This is AHSNs, MICs. The maximum grant your consortia can apply for is 3.5 million. The project can last up to 36 months. Please note, this is important, NHS organisations that are wholly funded by the government will receive 100% of their requested grant. If the NHS organisation does any work that is privately funded, they will be classed as a business. The funding amount will reflect this. You will not get 100%. You also need to set yourselves up as a business on IFS when you apply for this competition. So these are the types of organisations that Innovate fund. This includes businesses, SMEs, research organisations, universities, RTOs, catapults, public sector research, lots of things. There are definitions of business, the EU terms. You can follow this link. So if you get the slide deck, you can follow this link. Also in our guidelines on the IFS page, there are lots of links to the things. The amount of funding you receive will depend which category you fit into. State aid. So in order to be eligible to receive state aid, you must pass what is known as undertakings in difficulty. This is a test applying to limited liability companies more than 3 years old. If you have a parent company, the test can be performed on the parent or holding company. You should make sure that your business is eligible before you submit an application. If you're successful in your application, we will then apply the UID test as part of our viability checks. If you're unsure whether you're eligible to receive state aid, you need to seek legal advice. We cannot advise you on this. Further information is available on the website. If you are in difficulty, it's when more than half of your company's subscribed share capital has disappeared as a result of accumulated losses. That means, have you wiped out more than 50%, basically? Okay. This competition is a little different to some previous ones you might have been in. The lead can only incur up to 50% of the total eligible project costs. That's total eligible project costs, not grant. Any research organisations are able to claim up to 50%. If there are multiple research organisations, they would share this 50% between them. Okay, so collaboration is really important in this competition. We are looking for projects that involve multiple business partners. There must be evidence of a genuine collaboration. You'll need to explain in your application how all parties will contribute to the project and benefit from this collaboration. As we said earlier, your consortium must have at least 3 partners, including the lead, and involve an SME, an NHS organisation or academic partner. So making more than one application and resubmissions. Each eligible organisation can lead in up to 2 applications. You can collaborate on as many applications as you wish, as long as you can provide evidence that you have the capacity to do so. So if you say you can collaborate on 10, you need to prove that. Innovation leads will consider your application a resubmission if it's not materially different from a previous application. Your application is classed as a resubmission if it was previously deemed out of scope for another competition. However, if you were ineligible for another reason, for example, your project costs were too high, this is not a resubmission. Those of you who've been funded by Innovate before, it's very important to note that if you have outstanding final claim and IAR reports on any Innovate UK project, you cannot apply for grant funding in this competition as lead or partner. If you were awarded funding previously but didn't make a substantial effort to exploit, we will not give funding to you. Intent to exploit is very, very important for Innovate. So here are the key dates. These are all on the competition page as well. It's important to note submission deadline, as Penny said, is noon on the dot. The website simply closes. That's it. 12:01, you cannot submit. We recommend you apply as early as possible. You should see the traffic spike as we come up to midday. If there were any tech issues from our end, obviously we would account for that, but it is really important that you have everything from everyone, all of your partners, all your collaborators, uploaded by midday. If you have any technical problems or something won't submit, please get hold of us before the deadline as soon as possible so we can assist you. If there are any issues, we can work around them. So our users are all over the world. IFS helps them to collaborate with their project partners wherever they are. As you would expect, the majority of them are here in the UK, but then the next highest number is the US, then China, India, Colombia, and Germany. So, using the IFS system. First, you need to find the competition that you're interested in. So you use the keyword search box, as you can see here. Once you've found the relevant competition, click on the title. You will then see this second view. You'll see the tabbed view. Eligibility, criteria, scope, all of these tabs contain information and guidance. So there is a breakdown of all the different collaboration guidance, the state aid guidance, each question in the application. It's all broken down. Read all of this thoroughly, please, and then when you are happy, you can click Start New Application. So, to apply for a competition, the lead applicant needs to create an account with IFS. If you've applied before, you can just sign in as usual. You don't need a new account for every competition. You can use the Companies House lookup to search for your organisation, then you don't have to type everything in. If you're not on Companies House, you can manually enter it. We suggest that research organisations, academics, universities enter that manually, so you're not listed as a business. As mentioned earlier, though, if you are an NHS organisation undertaking privately funded work, you do need to apply as a business. So there are 3 sections to complete for this competition. The first section relates to the project details, and as you can see, it's application team. Here you can invite people from your organisation and other organisations because maybe you will not have one person filling everything in. You will have people from different organisations filling in their financial details, their CVs, background, things like that. Application details. Make sure your research category is correct because this is used to calculate your grant value. Again, if you have any questions about this, you can call our customer support team, email in. Project summary. This is to highlight the need or challenge, approach and innovation, and the outcomes. It's key for setting the scene for the assessors as it gives them an overview of your vision. The public description is published if your project is successful. Please be aware of confidentiality here. The scope. So you've heard a lot about scope earlier. It's really important the project is within scope to receive funding. Justify how your project fits the scope for the assessors. If you're not sure, again, you can get hold of someone, customer support. Section 2 relates to the application questions. So there are 11 in this competition. They cover 3 key areas, which we'll run through in a bit more detail over the next slides. These are the questions and the titles. You will find detailed guidance on how to answer each question next to each question. Please do read this. Please do what it tells you. It's the easiest way to make sure you score highly. Questions 3, 4, 5, 8, and 9 allow for appendices which are limited to 1 megabyte in size, and they also have a page limit. Again, all of this is stated on the website. So section 3 relates to the application finances, and I'm going to hand over to Andrea, who's going to talk you through this.
Thanks, Lydia. Good morning, everyone. So I'm just going to run over the application finances for you. And before doing so, I just wanted to highlight that although your business does not have to be UK registered within Companies House when you apply, it must be registered in order for you to receive funding, and that you are not able to claim any funding if you're an overseas organisation. So your company begins with FC, your organisation is set up as a branch, so your company begins with a BR, or that your company is based in Jersey, so your company number begins with JE. Just checking it's the right one. So, here are the eligible project costs that are considered eligible and therefore costs you can include. I'm not going to read the full list, but as you can see, there's quite a few areas to cover there, which I'm going to go over now. So for labour costs, you need to enter the position, the salary, and the staff, number of staff, and the days that project will be worked on. IFS will then automatically calculate the total cost. Just to know, if you have multiple people in the same role, on the same average salary, then you enter this into the role within project field. If an employee is part-time, you should enter their cost as a full-time equivalent. You can adjust the working days per year from the default if this is different for your project. And please note that dividends, bonuses and non-productive time cannot be included within your labour costs as they are ineligible. And that when making grant claims against labour costs, actual costs claimed must be supported with timesheets. Moving on to overheads. So we define overheads as additional costs and operational expenses incurred directly as a result of the project. These could include additional costs for administration staff, general IT, rent and utilities, etc. You can select from the three options you can see on the screen how you would like your overheads to be calculated. We class indirect or administration as overheads as those costs associated with back office functions such as finance or HR, whose primary function is to support the running of the business. However, they can only claim a portion of their time and their work needs to be additional to the delivery of the project, so not business as usual. Typically, these costs are not directly related to a particular product or service production. Direct overheads related to a particular product. Direct overheads are costs associated with staff working directly on the project, for example, including laptops, desks, office facilities, etc. We supply a simple form into which you can list each type of direct overhead, together with the methodology or basis of the appointment to that particular project. Again, these overheads would not be incurred if the project does not happen, so please don't put anything in there that would be business as usual. Moving on to material cost, you can enter and describe what materials you intend to use in the project, the volume and the cost. The materials listed must be project specific. Please provide as much information as possible. For example, if you just put £50,000 in there, that doesn't provide us with enough detail. And what will happen is, if you were successful, our project finance would get in contact with you asking you for more information. So it's just best to put the information up front. Any items which would normally or would usually depreciate as per your company's policy should be listed in capital usage. And materials supplied by associated companies or subcontracted from other consortia members, these must be listed at cost, excluding any profit or element margin. Here you'll need to describe how you're using the equipment, whether it is new or existing, the new purchase cost, how long you're depreciating over, and the residual value at the end. These calculations will need to be in line with your accountancy practices for your business. Subcontractors, if this cost is going to be significant, then you will need to justify who, why, and what you need from them, both here and in your application. It's important to note that you justify the use of subcontractors in your application, especially those that are not UK-based. As the assessors do not see this level of financial detail, they'll only see the overall cost. If you use a parent or sister company, please ensure you list at cost and do not include any profit. Travel and assistance. Here you would include things such as essential meetings that need to happen during the project. You cannot include any sales or marketing activity as this is ineligible. And travel costs must be at economy travel only. You should be prepared to provide a breakdown of these costs if the project finance reviewer asks for more detail. For example, they might require you to split a trip into its subsistence, accommodation and travel components. Other costs, please check the finance guidance for what costs can be included here. If you're unsure, please do not hesitate to contact our customer support. Any other costs which don't fit the previous categories, for example, training directly attributable to the project, licensing new technologies, patent fine costs for new IP, so for SMEs this can be up to £7,500. Please can you ensure there's no double counting and that all costs are justified? Funding rules, as previously mentioned, the level of funding awarded will depend on the type of organisation and the type of research being undertaken in the project. IFS will calculate your percentage based on the answers that you've input into the system. And this table, I'm not going to go into great detail about this table, this is just to highlight how the funding would work across businesses, academics, RTOs, and how that cost may be associated. So as you can see, SMEs can claim up to 70% of the project costs. And as Lydia highlighted a few times earlier, just a reminder that NHS organisations are not 100% funded by the government, can receive 100% of the requested grant. However, if they are involved in privately funded work, they would then have to be classed as a business and the funding amount would reflect the size of their organisation. So as the table before, if it works out to be an SME, then the cost would reduce down to 70%. They will not receive 100% of the funding and they will need to set themselves up as a business when applying for this competition, so it's quite important that you get this right within IFS. Moving on to academic partners. Academic partners in your consortium will need to fill out a JES form. They should be familiar with this. The form validates costs for us. As Innovate UK, don't have access to the JES system to extract the information ourselves, so you will need to fill in the information on JES and make sure that it's at council status and then upload it as a PDF within IFS. When they've completed their JES form, academics will need to include their unique reference number on IFS and input their figures. Please ensure the figures you provide are identical, and again, the form must be with council status and uploaded to IFS as a PDF. You must also ensure academic partners complete the justification of resources and pathways to impact on their JES form, as this information is also looked at by the assessors. Any questions on JES, then please call or email the JES help desk, and you should be able to find this information on our website. Submitting your application. This is a summary of the project costs available to all organisations in the project. You will not be able to see any more detailed breakdown of anyone else's cost. Just to note that the assessors will see this, and just to highlight that the total project cost for this competition can be up to a maximum of 10 million. For collaborative applications, IFS will highlight the lead applicant and any partners who have outstanding project finances to be completed. All finances must be included in the application form before the lead applicant can submit it. So if there's any of your partners who haven't filled out all the relevant information, you will get an error message on the IFS system. It will also check that your research participation costs are within the required limits. However, IFS don't validate project cost. It is your responsibility to ensure all costs are within the eligible total project cost as stated in the brief and guidance. And just to highlight that we are able to track site usage and submission uploads, and as Lydia highlighted earlier, this table shows a number of applicants submitting their proposals each hour leading up to the noon deadline. And as you can see, the majority of applicants leave it to the final hours. So we strongly recommend submitting your application early, in good time, to avoid any last-minute technical issues. Quite often we have, so with the smart competition, due to the volume of applications being submitted in that last hour, quite often the system will crash. So the earlier the better. That would be really helpful. Thank you. Now I'm going to hand back over to Lydia, who will explain how the assessment process will work.
I would just like to state that IFS does save your progress. You don't have to upload everything at the same time at 5 minutes to 12. So everybody can log in and update their relevant parts. And only the lead will see the error messages. So you need to be in constant contact with your collaborative partners to make sure everybody's done what they should have done, because they will log in as themselves to do their bit and everyone will log in separately, so the lead will get all of these messages. So you need to be on top of that, but you can do that as soon as, and it won't be submitted until you press that final button, but it will save as you go. Okay, so once submitted, the application is assessed. The first thing we do is a scope check to see if it's within scope. And then it's reviewed by 5 independent assessors. The feedback is collated into a final score, and then there will be interviews. Assessors tell us they want clarity, detail, justification, and to see that the applicant has presented a viable opportunity for growth with exciting innovation where public funding will make a real difference to developing their idea, and that they have the right people and the right approach to run a successful project and exploit the results. Answer the questions in the guidance so the assessor can award you the maximum marks. Even if you have a fantastic idea, if you don't answer the questions as requested, you will not score well. Make sure your application reads well. You want to keep the assessors engaged and interested. They will be reading a lot of applications, so make sure yours stands out. Okay, so once we have scored everything, we look at what we call a panel sheet. It collates all the assessors' scores. So the left-hand column, score average, shows the score for a particular application. So here you can see we have 5 different applications. The green highlighted column shows the score spread. This is the difference between the top and bottom scores within an application. The next 2 columns let us know whether an application has been marked either out of scope or not recommended for funding. All of the applications that go to the assessors should be in scope, but maybe an assessor just disagrees. So we do look into this. If there's a 3 or more in either of these columns, we will review the scores and the feedback to find out why. Maybe the assessor misunderstood the scope, or maybe they've picked up on something that no one else did. So we do look into further detail as to why they have not recommended something for funding, or they don't believe it's in scope. If we see a score spread of 30 or more, we will look into the scores to see if there's an outlier. So here you can see a breakdown of 1 application scores. The green box highlights a single assessor's score across all of the questions, so that top line. The purple box is all 5 assessors' scores for a single question. If we see a difference of 20 or more between the highest or lowest score and the next closest, we'll check the feedback. If we feel the score is unjustified, it would be removed as an outlier. In this example, you can see Assessor 3 has marked 62. We would check the feedback, and then we would remove that, and the score would be adjusted. So it can go either way. It can be a low one, it can be a high one. If everybody has marked sort of in a group, and then there is one outstanding or low standing, we will look at the feedback as to why, because again, maybe they've picked on something no one else has, but we don't just go, oh, it's 20, we'll take it out. We will look at the feedback and see if it is justified, and then the score will be adjusted without that outlier. The lead on the project will be notified when the feedback's available. They will go onto the IFS dashboard to view the feedback. If you are invited to interview, you will have a chance to respond to the feedback, which gets sent to the panel, who will read it prior to your interview. Response to assessor feedback is optional, although we do suggest you do it. We do ask our assessors not to ask questions, because if you are not successful, you don't have the chance to respond, but they do make some questioning statements. So if you get invited to interview, your response to feedback is really important, because you can fill all the gaps and all the queries they had. It can be up to 6 A4 pages in a single PDF or Word document, including charts or diagrams. This will be sent to the panel. They will be familiar with your application, your response to feedback, and the presentation that will be required from you at interview. Okay, so project setup for successful applicants. So you've got through, you're successful, congratulations, then what? So these are the stages that need to be completed by all of the partners within 30 days. You can start project setup as soon as you've been notified that you're successful. Projects need to start within 90 days of this successful noting. We no longer issue a conditional offer letter after notification, as organisations sign up to our terms and conditions when you submit the application. The lead has visibility of the progress of all partners, so it is their responsibility to chase them and get this pushed through. The lead needs to provide a collaboration agreement and exploitation plan. Each partner will need to provide their bank details and a finance contract. Project team. So each organisation can add new people into the project to be listed as either the finance contact or project manager. Individuals can allocate themselves and can take on both roles if they so choose. Applicants will only be able to invite people from their organisation to join the project. We will assign you a monitoring officer who will be your main point of contact throughout the project. We'll also review your finances to check that your costs are eligible and the businesses involved are legal entities and can meet their match funding requirements. Communication at each stage will be done through IFS. If there are any issues, please ensure all details are correct, up to date and regularly monitored. Don't put an email address of someone who then goes on leave or leaves the company. It happens quite a lot. So make sure that the contact details you give us, we can contact you on, because if we are waiting for something from you and the 90 days runs out, there is a risk that your funding will be withdrawn. In order for us to ensure we're paying the correct organisation, we need to verify bank account and the bank account we will be paying your grant into. The simplest way of doing this is by providing a copy of redacted bank statements. We're not interested in looking at the transactions going through your account. It's simply confirmation that the company name you use when you've created your application matches that on your company bank account. You cannot make a change to a project before the project starts. If you need to change a partner or move costs, the funding would be withdrawn. You'd need to reapply in a future competition. The collaboration agreement. So we frequently see projects get held up by the collaboration agreement. Start thinking about this now. You won't be able to make your first claim without it, and it could hold the whole project up. If you are successful and start your project with grant funding, you need to be aware of the fact that we pay your claims quarterly in arrears. If you're a small organisation, be aware of this and manage your cash flow. It can catch companies out because there might be significant upfront costs. Another thing to bear in mind is that all costs have to be incurred and paid between the start and end of the project. You cannot claim for costs incurred before the project has received confirmation to start or after it is finished. Your project can continue, but we will not fund it. So here are the key dates again. Again, all of this is on the website. I know there's a lot of information in this presentation, and even for those of you that have applied before, this competition is running a little differently. As I said, there's a recording of this briefing available from the KTN. If you'd like a copy of the slide deck, contact our customer service team. All the guidance, both competition-specific guidance and general, is available on the website. But if you have any questions, don't hesitate to get in contact with us sooner rather than later, please. And all we can say is good luck. So, do you have any questions about how to apply to Innovate? And if you do, please wait for the microphone.
Hi Lydia, I'm Simon Harris from the NHS East Midlands Radiology Consortium. We're currently in Innovate UK Wave 2 testbed, and I've looked through the guidance and applications in terms of eligibility to apply for this one. A sentence you had on your slide alarmed me because that's not what says on the website in terms of previous applications. The current website guidance is about failure to exploit in the current testbed, and that will be marked against anyone that was reapplying. But what your slide said was, if you've applied before, you are ineligible. So can I just get some clarification on that?
It's the IAR.
That actually relates to if one of your awards has ended. If your award is still live and you're still working on the project and it's not got to the end of the project stage yet, then you are eligible to apply. Okay. So the IAR and the outstanding final claim relates to projects that are finished.
Okay.
So I think that's okay. Thank you.
Thank you very much.